Hi, I'm Prithviraj Bose, one of the leukemia faculty at MD Anderson Cancer Center in Houston, Texas, and I focus on myeloproliferative neoplasms. I spoke on the management of cytopenias in myelofibrosis at the recently concluded Texas MPN Workshop in San Antonio at the end of August 2022, and I'll sort of summarize some of the points I made during the talk. Cytopenias in myelofibrosis are predominantly anemia and thrombocytopenia. Fortunately, we don't struggle that much with neutropenia, but anemia and thrombocytopenia do represent significant challenges to patient management. The drugs we have today are not particularly effective, and there is nothing approved specifically for the improvement of cytopenias in patients with myelofibrosis. Currently, we use things like danazol, erythroid stimulating agents, and immunomodulatory drugs, for example, low-dose thalidomide, to try and improve cytopenias, particularly anemia. Thrombocytopenia is harder to improve. There is some benefit with low-dose thalidomide, 50 milligrams a day, and some with danazol as well. But overall, presents a difficult problem. Now, in sort of to look at how best this difficult problem can be tackled, one can look at it really in two ways. One would be drugs that actually improve cytopenias. For example, luspatercept, the activin receptor ligand trap, is being developed in a phase 3 clinical trial at this time compared to placebo in patients who are on a stable dose of ruxolitinib and still need blood transfusions. So that would be an example of a drug that's being developed specifically to improve a cytopenia. And there are other drugs which do multiple things. And one of them would be amelioration of cytopenias. Some drugs that come to mind there are drugs like Pelabresib, the bromodomain inhibitor that's also in a phase 3 trial right now called the Manifest-2 study. And this is in combination with ruxolitinib compared to ruxolitinib and placebo in the front line. And this is a drug that is certainly known for its synergism with ruxolitinib in terms of enhanced spleen and symptom improvement, but it is also a drug that can improve anemia. And that's been shown in the phase 2 Manifest trial, in which there were 3 arms where Pelabresib was studied alone after ruxolitinib, or in people who were not candidates for ruxolitinib, or added on to ruxolitinib in people getting, or in people that had a suboptimal response to ruxolitinib alone, as well as in the front line in combination from the get-go with ruxolitinib in patients who were JAK inhibitor naive. So we have a lot of data on this drug in over 200 patients that have been presented at several meetings. And this is a drug that holds some promise for improving anemia. Now, momelotinib is a JAK1, JAK2 inhibitor that also improves anemia. And it does so by inhibiting something called ACVR1, also known as ALK2. And this ultimately leads to suppression of hepatic production of hepcidin. And if you reduce the production of hepcidin, you sequester iron less. So iron gets less trapped, or less iron is trapped, I should say, in the reticuloendothelial system, so that more is available for erythropoiesis in the bone marrow. Momelotinib has just completed a very successful pivotal trial called the Momentum trial. In the second line, these were all patients who had previously been exposed to JAK inhibition, and these patients had to be anemic and symptomatic. The primary endpoint was actually symptom response, and anemia response was a key secondary endpoint. This trial met all its pre-specified endpoints. It was a comparison to danazol in the second line setting. So momelotinib's approval is certainly eagerly anticipated. This is a drug that had previously also been studied in 2 other large phase 3 trials, the Simplify 1 and 2 studies, Simplify 1 was head-to-head versus Rux frontline, and Simplify 2 was also mostly against Rux, but in the second line setting in patients who were mostly intolerant to ruxolitinib, got either momelotinib or ruxolitinib again. But this is a drug based on the strength of all three large trials, we certainly highly anticipate will be approved sometime next year. Now, it's important to mention pacritinib. Pacritinib is a drug that's already approved. This was approved in February of 2022. And this is a JAK2 inhibitor sparing JAK1, so only JAK2, but also inhibits something called IRAK1, which is important in the innate immunity and inflammasome pathways. So by virtue of inhibiting JAK2 and IRAK1, this is a drug that is remarkably non-myelosuppressive, and certainly much less myelosuppressive than ruxolitinib and fedratinib, the two JAK inhibitors that preceded it. One major problem, a really vexing problem that we've had to deal with up until pacritinib's approval, was that neither ruxolitinib nor fedratinib have been studied in patients with platelets less than 50,000. And so now pacritinib actually fills that niche in the sense that it is approved specifically for patients with myelofibrosis whose platelets are less than 50. So it's really the only JAK inhibitor with data in this setting, and certainly that is approved in this setting. But pacritinib's potential efficacy and role is not limited to just that. It's actually been studied in patients up to 100,000 platelets, not just 50, in the pivotal trial that was called PERSIST-2. And this was a really well done trial where they included patients who had had prior ruxolitinib, and they also allowed ruxolitinib as a comparator in the best available therapy arm. So this was a positive trial with pacritinib being superior for both spleen and symptoms at the 200 milligram BID dose, which is the approved dose, to BAT in these patients who were a mix of JAK inhibitor naive and JAK inhibitor pre-treated patients. And like I said, the BAT could be ruxolitinib and was ruxolitinib in about 45% of the patients. So pacritinib has a label for under 50, but certainly has data supporting its use in patients up to platelets of 100. And this is a drug, because it's non-myelosuppressive, that can be given at full doses in patients with cytopenias. And that's important because, at least with ruxolitinib, we do have to dose reduce because it's myelosuppressive, particularly for platelets. That's in the package insert, where the dosing is different based on the platelet count. So that's really, I think, most of it in terms of the new drugs. I would also like to highlight that there are a couple of alternative dosing strategies for ruxolitinib, which are important to mention. Ruxolitinib causes anemia and thrombocytopenia, and the anemia that is caused by ruxolitinib is not prognostically deleterious like disease-induced anemia is, but it's a problem. Practically, it's a problem because patients need transfusions or dose interruptions, reductions, and other interventions for anemia, etc. So a trial called the REALIZE trial looked at using 10 milligram twice a day, regardless of the platelet count, in patients with anemia of ruxolitinib. And then after 12 weeks of doing that lower dose, escalating as feasible. And this trial showed, a high rate of, spleen response with this strategy, showing that you don't lose much by doing this, even though we know that ruxolitinib spleen responses are dose dependent. This seems to be a nice practical alternative where you use the 10 BID for 12 weeks and then go up as tolerated in anemic patients. And then there's the EXPAND study, the final results of which were just published. And this is a study looking at the optimal dose of ruxolitinib in patients with platelets between 50 and 100. Like I alluded to, ruxolitinib dosing is platelet based. And currently the FDA's label, the US label, says that the dose should be 5 milligram BID in the 50 to 100 platelet range. So the EXPAND study showed that you can actually safely give 10 milligram BID, which is a more effective dose in this 50 to 100 platelet subgroup. And actually, taking a cue from that, the EMA in Europe has changed the label for ruxolitinib to the effect that if the platelets are between 75 and 100, the approved dosing is now 10 BID as a starting dose. In the US, it is still 5 BID for the 50 to 100 range, but many of us actually have been using the 10 BID in that space, and the EXPAND study certainly validates that approach. There are many alternative, additional strategies that are newer, that are earlier in development, that I also sort of touched on. But I think those are the main drugs at this time, or on the horizon, that could be soon available soon, that I think are most relevant to the subject of cytopenias in myelofibrosis.